Hello, I'm Dr. Janet Wright. I'm Senior Vice President for Science and Quality here at ACC, and it's a delight to be joined by Dr. Thad Waits. Dr. Waits is the incoming Board of Governors Chair-elect. Welcome, Thad. We're here to talk about the problem of hospital readmissions, those preventable or avoidable readmissions. I know that you've been working in Mississippi. Share with our audience what you're doing there.
Right. In Mississippi, we have a fairly high prevalence, in fact, a very high prevalence of cardiovascular disease. We have a lot of diabetes, a lot of obesity. We happen to be the most obese state. We're working on that hard, but nevertheless, those are the facts. And as a result, we do have a lot of congestive heart failure. The hospital in which I work carries a percentage of about 28% readmission rate in calendar year 2010, which I think is pretty well the standard around the country right now.
Right.
We're working hard on trying to improve those numbers, and I would say we have two processes that are working fairly good. One of them is telehealth. That's done through a home health agency that's run by the hospital, and it's right at this moment voice and data, not television monitoring, but voice and data.
Right.
And so the nurse practitioners, or in this case just the nurses actually from the home health service, are able to deal with the patients, educate them, and do what's necessary to help treat them at home. As a result, the readmission rate for this group is 3%.
Remarkable.
As compared to 28% for the others.
Right.
And then we have a different group that is run by a nurse practitioner. He's an independent nurse practitioner. He's not hired by the hospital to do three things. One is home care, the other is nursing home care, and then the final is a congestive heart failure clinic. Now, that particular clinic, he is an employee of the hospital for that clinic. And by taking care of what he calls the low-hanging fruit, of educating the patients, of adjusting their medications, by doing all the really nuts and bolts things of heart failure care, he has now a less than 8% readmission rate for close to 200 patients. And in that 8% are some patients that were properly readmitted for example, ICD management.
That's really remarkable success, and that's over a pretty short period of time.
Right, that's over just over a year.
Wow,
right.
That's impressive. In your position as Board of Governors Chair, will hospital-to-home or working on readmissions be part of your agenda?
Absolutely. Hospital-to-home is a big part of what we're doing within the Board of Governors. And remembering that ACC and Board of Governors includes CCAs, the Cardiac Care Associates, and we have a representative of the CCAs on the Board of Governors, I think this will very much be a CCA prerogative, that they'll be the ones that will largely be managing the outpatient care of these congestive heart failure patients.
You know, I think even more than door to balloon, hospital to home speaks to teams of people and getting those teams on the same script and coordinated. Do you see that as part of the charge?
Absolutely. It has to start in the hospital, in the discharge, or as I think you have coined the term, it needs to be the transition and not just the discharge. We need a handshake instead of a handoff. And in so doing, then the patients will be getting the proper care as soon as they get home as they did in the hospital. We need, as a team, to work on the discharge medications. As a team, we need to work on coming to see the doctor as an outpatient and communicate. We're going to have to do a better job of communicating.
You know, Thad, you remind me that 2010 Hospital to Home H2H focused on building a community, and now there are over 1,000 participants in Hospital to Home. The steering group, the advisors, national advisors, have now turned their attention to challenging groups around the country who want to reduce admissions. The challenge they're issuing first is to try to get a patient in to see a provider, maybe nurse, maybe doc, within 7 days of discharge.
Right. And that is a large challenge. I know in our system, like in so many places in the country, the primary care doctors are not necessarily taking care of the patients in the hospital now. We have a big hospitalist group. They're doing wonderful care. And then the primary care doctors are also, but there's the lack of transition between the two, and that's such an important part of it. So we do have to set up a system so that the primary care doctor is ready to take that patient within a week or 10 days.
We've been talking with Dr. Thad Waits. He's incoming chair of the Board of Governors of the American College of Cardiology.